So our talk for today will start the discussion on study designs in medical research. And the focus will be on observational studies. But before that, I'll give a broad overview. So we're going to look at why study designs matter, look at some classification of study designs, and then we're going to focus on these 4 different types of observational study designs. And as learning objectives for this entire section on study designs, we hope that by the end of this session, you should be able to describe key study designs that are used in medical research. You should be able to clearly distinguish between observational and experimental designs. You should be able to identify the key features, the strengths, and the limitations of each of these designs. And you should also be able to recognize which study designs are appropriate for which kind of research purposes. And lastly, you should be able to interpret real-world examples of observational and experimental designs. So why do study designs matter? Study designs shape the answers that you get, even for the same research question. So you can imagine that there are 2 different studies. There are 2 studies that have asked the same research question, and they are studying the same disease or the same kind of treatment. One study selects one kind of design, another study selects another kind of design. The result that you're going to get is not going to be the same. So the result you get will depend on the kind of study design that you're going to select. So one thing that you should note when you're thinking about study designs is that when you ask a research question, there is a truth that you can attain. And your goal is to design the study in such a way that you get closer to that truth as much as possible. How close you get to that truth depends on the kind of design that you prepare. So if you use a design that is not appropriate, you will not approximate that truth very well. If you use a design that is very robust, very clear, you are more likely to hit the truth more closely. So if you get the design right, you are likely to get results that are valid and that will be useful. So this can be results that can translate into clinical practice or into policy. But if you get the design wrong, you do not only waste your own efforts and the efforts of all the other staff who worked on that project, but you also lead to misleading conclusions. And other people are going to be using your results for their own studies, and they're going to use it into practice, which is really problematic. And that means that you have to take the issue of study design very carefully to know whether the study design that you are going to be using is the correct study design for getting the kind of truth that you want to get out of your research question. So note that study designs determine what you can learn. You cannot ask a question and take a study design that do not permit you to answer the kind of result that you want. They also permit you to know how confidently you can say, what confidently your study can say. For example, you can't do a cross-sectional study and at the end, you conclude that there is a causal relationship between probably a risk factor and an outcome. The cross-sectional study in that setting is not the best, and we are going to see in more detail why. And your study design also determines whether others can believe what you say. Right? So if you present a study and you end up you do something like a very basic design, like a cross-sectional design, and you end up trying to tell people that they should take this action or not, people will actually look at the design and determine whether you can draw those kind of conclusions. So design really matters a lot. So a flawed design, no matter how good your analysis is, a flawed design cannot rescue cannot rescue a good analyst cannot rescue a flawed design. So if you start with the wrong design, no matter what you do, even if you're an expert in data analysis, you cannot sort that out. So let's look at classification of study designs. And the first way that we can look at it is whether there is some form of intervention. And so if you have studies that intervene, then you have experimental studies. If you have a study that does not apply any form of intervention, then they are purely observational. So observational studies, you, the investigator or the researcher, you just observe patients. In interventional studies, you, the researcher or the investigator, you actually do some form of intervention. For example, you can give a drug, you can do a procedure, you can do maybe something like psychotherapy. There is some intervention that you have applied. And so you can see that in research, observational studies, the researcher's role is just to observe. In interventional studies, the researcher actually assigns an intervention. And on here, observational study examples, which are all studies that do not involve any form of intervention, and that's why they are observational. And on this side, you have studies that are experimental or interventional studies. And we're going to see these aspects next week. So here is another broader classification. And as we saw in our first very lecture for this year, we discussed about the PICO framework. And here is a little summary of the PICO framework. I'm sure everyone is familiar at this point because we've been repeating it over and over. And so one way that you can look at it, which is very helpful for translating your research question into a study design, is to think about whether your study is just purely a descriptive study, right? So you just have a certain population and you want to describe a certain outcome in that population. So only the P and O components of the PICO are relevant to you. And the way the study designs that kind of work in those kind of purely descriptive scenarios are a simple case report or a case series. We'll see that in detail. Qualitative studies are also very descriptive. And also you have surveys. These are a type of cross-sectional studies that are just purely descriptive. You just get like kind of a prevalence measure. But note that also you have cross-sectional studies, some other form of cross-sectional study called analytic cross-sectional studies. So unlike descriptive studies, analytic studies can be both observational analytic studies and experimental studies. So you get a case control study and a cohort study. All of them are analytic. What makes it analytic is the fact that you are kind of doing some form of comparison between one group and another. And so in cross-sectional studies where you kind of assess maybe a comparison of an outcome, let's say those who have hypertension and those who do not have hypertension, there's some comparison. In that case, you have an analytic cross-sectional study. But if you're just purely describing the cohort, then you have a pure cross-sectional study, as is often the case in surveys. So for experimental studies, there are different ways that you could classify them. You can look at whether there is a control group or no control group. You can look at whether there's blinding or no blinding. But generally, I think the most relevant form of classification would be whether there is some form of randomization or no randomization. And we'll see that in the talk on experimental studies. And for randomized controlled trials, you can have different types of designs. You can have a parallel design, crossover design, and cluster design. And we'll see that in more detail later. So before we go further, I think it's very critical to kind of have a very intuitive understanding of how different study designs vary. And one way to think about it is that as you move from clinical observation to the most robust form of evidence, you actually start with generating a hypothesis to establishing a cause-effect relationship. So in a clinical observation, imagine you are a doctor in a hospital and you notice that patients who are having lung cancer report a history of smoking a lot. And that kind of brings to your attention that this is a probable concern. And so you write down a case report or you put together a number of patients in a series and you do a case series and you report it to raise an alarm. This is similar to, for example, you're a doctor in Wuhan, maybe in December 2019, and someone presents with some rare form of respiratory tract infection that doesn't really match typical patterns, and you start to describe it. And maybe that later on comes out to be COVID-19. So it always starts with a clinical observation, or I mean, for clinical studies. So it could be something else you observe in public health practice or other forms of health research. And so the first point is you kind of see something strange and you're wondering what that thing is. and it raises an idea and you're wondering, what's this thing? What causes it? And you can go a step further by describing it. So you can take a number of patients, maybe you now collect data for like 50 patients and you describe the characteristics of those patients and so on. A little bit further in finding out more details about it and maybe establishing what the cause to what you're observing is, you can do a case control study. And so let's say, for example, you are still the doctor who observed that patients who had lung cancer were smoking a lot. So you could take some of your patients that have lung cancer, and you pick some other patients in the clinic who do not have it, and that's the control. And you look back in time and how many of them smoked, or who smoked, who did not smoke, or who was exposed to smoking and who was not. And you kind of compare the risk of lung cancer or the odds of lung cancer in these two groups. But this has some limitations. And for that reason, you can even go further and we'll see the limitations that this case control study kind of poses. A step further in identifying what could have been the link between smoking and lung cancer, you could actually just take new people who are smokers, and then you take another group of people who are not smokers, and you follow them up for a certain period of time to kind of establish maybe whether this smoking is really the cause of the cancer. Looking forward, that means that you take them today and you look into the future. And the next thing you could have done is to do a randomized control trial, which is you take people who smokers, you put them in one group, you take another, people who are smokers and non-smokers, and you randomize them, and then you give smoking as an intervention and observe whether people develop smoking over time. But this is unethical, and we're going to see that there are situations where randomized control trials might not be the best study design, and in that case, we might go back and lean more towards cohort studies. And if you combine several randomized control trials, you can do some form of a systematic review with meta-analysis to kind of pull the evidence together to propose even a stronger evidence that comes from multiple robust studies. So this is very important in understanding the gradient of the evidence and what the kind of evidence that each study design can provide to you. We'll see that in more details. And so these are the different types of observational studies that we are going to look at. So let's start with the first case, which is a case report. So a case report, unlike a case report, you just describe a detailed story of a single patient. So you can give the clinical presentation, how the disease manifested, what you think the disease could be. And if you have a good number of those patients, let's say more than one, up to 30, typically you have like a maximum of 30 patients in a case series, and you describe those group of patients, their characteristics, how they presented, their history, and you start to kind of give a hint or hypothesis of what you think might have been going on with these patients. And when do you use a case report? You use it when you have, when do you report a case or a case series? Usually we do this for rare or unusual diseases. And you can see, for example, in the case of COVID, so you can have a totally new disease that you do not know that it's worth sending an alarm out to the research community or to the medical community that this is worth looking into. And so you can also have a situation where you have, you're treating a patient and you get some kind of unintended responses to treatment, or you see something quite unusual in the whole management of the patient. And I think one particular case that comes to mind for me is how sildenafil was discovered as treatment for erectile dysfunction. They were actually just testing patients to see for sildenafil for cardiovascular treatment. But they noticed that these patients they noticed an unusual behavior among these patients, and so they ended up reallocating the drug as treatment for erectile dysfunction. So in that case, that kind of observation can actually be interesting to describe for the rest of the medical community. You can also use case report or series design when something is new or emerging, like COVID. And these are really great as a starting point for kind of generating an idea and stimulating further research. So what are their strengths? They are really the foundation or the starting point for future research, so help you generate hypotheses. and they help in the recognition of new or rare conditions that we have not seen before, or conditions that are very, very rare. So you want to signal that out. And they are usually the first step, as we saw in the last slide, in a line of investigations. And so they have also limits. So they are the lowest level of evidence. So this evidence is quite anecdotal and it's coming from one single patient. So the evidence is really low. There is no control group, no comparison. So this really is a big limit, and we are going to see why later. We cannot infer a cause or effect relationship. Remember, they are really early in that hierarchy of evidence. And they also have a publication bias issue, because usually people only publish cases of that are quite interesting, but there are cases that might not be interesting that are also very important and needs to be published. So this is an example of a case report or case series. So these investigators here, right in 1881, described some rare complications of typhoid fever. And so when they raised these, further investigations were done. And that's how today we are able to treat even further complications of typhoid fever. In this other example here, we describe 2 cases of patients who had vulvar hematomas. So these were outside obstetric settings. So these were not women who were giving birth and then develop obstetric develop vulvar hematomas. These were just spontaneous cases, so they were quite interesting, and we wrote it up and published it in the Pan-African Medical Journal. So that's before we go to cross-sectional studies, cohort studies, and case control studies. There are some concepts that are very important to understand. And I'm sure everyone is already familiar with this, but I'll just go over it. The idea of an exposure and the idea of an outcome. So what is an exposure? It's usually the beginning, or maybe the cause or the risk factor, which can be, for example, smoking, some form of treatment if you are like in a trial. And then there is an outcome, which is the result that you desire or that you want to see. So it could be maybe something like morbidity, mortality, it could be recovery. So usually in a study, you start with an exposure. Particular studies that want to link a cause to an effect, you start with an exposure and with an outcome. And other factors that are very important in understanding the subsequent study designs is this issue of time and temporality. And you ask yourself, did the exposure clearly occur before the outcome? And this is very important. For you to really establish causality or cause and effect, the exposure has to come before the outcome. So temporality is very, very important. Usually when people are early beginner researchers, they usually maybe do something like a cross-sectional studies, which cannot really establish clearly that an exposure came after an outcome. And they kind of try to say that something caused another, which they cannot say for that study design. So it's very important to understand the idea of temporality. The other thing that is very critical in understanding is the direction of inquiry. So if you're designing a study, how does the exposure flow towards the outcome? So if you start from the exposure and you're looking towards the outcome, you're looking forward, you could have something like prospective cohort study or cohort studies in general. If you start from the outcome and you are looking back to the exposure, which is the direction of inquiry, then you can have something like a case control study. So the direction of inquiry is really critical. And so this figure here kind of summarizes very well. So let's say you're standing here today and you are assessing your exposures and you're looking forward. You have a prospective cohort study. Even in a retrospective cohort study, as we're going to see later in more detail, your direction of inquiry is still forward from exposure to outcome, although you are getting data historically. So you are here today, the exposure still came before the outcome, but you are getting exposure data, maybe from medical records or something. For case control studies, you are at this point, and your direction of inquiry is from the outcome to the past. We'll see this in more detail. So let's start with cross-sectional studies. So a cross-sectional study is a study that looks at both the exposure and the outcome at the same time. The exposure and the outcome at the same time. So when you think about it, think of it as a snapshot. So like you can see in this photo, you have people who have the exposures, the outcomes, all, and you're taking a snapshot, like kind of a group photo. You're capturing everything at once. You cannot tell if the exposure came before the outcome or not. So it's one-time snapshot. You can't tell anything about temporality. You don't know whether exposure came before the outcome or not. You can't. And so these studies, these cross-sectional studies are always sometimes called surveys, because almost all surveys are really cross-sectional in design. Another way that some researchers would describe it is as epidemiologic studies, or just prevalence studies, as they are the ideal study design for measuring prevalence. They also answer the question, what is happening? So the answer in what point in time, what is happening now? So you take a snapshot at that moment and you describe. And so, for example, you can say, what proportion of adults in Cameroon currently have hypertension? And this is something that we are trying to do with the May Measurement Month, which is an international endeavor to assess the burden of hypertension worldwide. And so in Cameroon, the Cameroon Cardiac Society and CRENC has been doing a nationwide survey where we are assessing people who are measuring blood pressure in markets, in churches, and places. And so these usually occur within the month of May. And so Prof. Anastas has been leading those efforts. And I think one of the strongest evidence that we have in Cameroon in terms of the burden of hypertension is really informed by MMM, because we've recruited over 50,000 patients in the past years. And next month we'll be doing MMM 2025. Okay, so another example could be, for example, you could ask yourself, how many students in Boya with high social media use report anxiety today? So you're just going to describe the degree of anxiety among those who are using social media in a given period of time. So as you can see in this graph, there is no direction of inquiry. There's no exposure leading to outcome. Both the exposure and the outcome are studied at the same time. So you take subjects and you just kind of have a cross-sectional view of the exposure and the outcome. And so these are some key features that you should note. And I'm repeating some of these for emphasis, because I think this is where the confusion often comes on. They are measured at the same time. There's no form of follow-up. You cannot determine temporality or causality, because you can't tell whether the exposure occurred before the outcome. They're the best studies for studying, they are best study designed for studying prevalence, and they're often used in surveys, health assessments, and screening. So let's look at some of the strengths or advantages against some of its limitations. So just like case reports and case series, they're a good starting point for generating hypotheses. They're also quite simple, quick, and often not very expensive to conduct, except you're doing a very, very large scale cross-sectional studies or surveys. They can also be great for assessing multiple exposures and outcomes, because you can use the same questionnaire and you kind of assess several different exposures and outcomes at that same moment when you are conducting the study. And they're also really the ideal study design for prevalence. So if you think about prevalence, think about cross-sectional studies. They are not without limitations. Like I emphasized, they cannot establish temporality, because both exposure and outcome are captured at the same time. You cannot determine causality, because if you do not know whether exposure comes before the outcome, you can't tell whether something is the cause of another. And they are not really great for studying rare diseases or diseases that develop slowly, because you are going to not have enough sample in the numerator to actually have a substantial determination of the prevalence. And they might also miss patients who are already recovered or patients who have died. And usually they are susceptible to selection bias, to recall bias, and since it's often a questionnaire that you administer, the way that you frame the questionnaire also matters a lot. If you do not frame it well, then your assessments are going to be wrong. So this is another example of a cross-sectional design, which is one of, I think this is the biggest survey in HIV in Cameroon, the CAMFIA, which is the Cameroon version of the FIA studies. And so the CAMFIA is a nationwide, kind of almost designed like a census. So people go door to door and they screen for HIV and other parameters. And so our last CAMFIA is the CAMFIA 2017, which is actually provide us with baseline details for giving the epidemiological picture of HIV in Cameroon. And the currently the CAMFIA, the second CAMFIA, which is CAMFIA 2024, is ongoing now, which we hope to see how the picture of HIV in Cameroon looks like. Here we also have an example of a cross-sectional study that we did in the IeDEA, led by Prof. Anastas. And we looked at the burden of hypertension at baseline, so as patients were enrolling into the IeDEA study. So let's move to the next study design, which is the case control study. We see as we move forward, we are moving from weaker evidence towards stronger evidence in terms of determining causality, and you will see the limits and the advantages of each. So for case control studies, you start with people who have the outcome, who are the cases, and you compare them with people who do not, who are the controls. And then the direction of inquiry is to the past. So you look back to see if those who have the cases versus those who do not, that's the control, whether they were exposed. And you can think of it as maybe you're an investigator and you pick some people who have the cases, you pick controls, that's people who do not have the cases, and you look back in time to see whether they were exposed to something. So for example, the cases might be people who have lung cancer, the controls might just be other patients who are healthy, and you can apply some matching to make sure that these people are kind of comparable. And then you look back in time to see whether maybe they were exposed to some asbestos or something. So this will be a pathogen like a virus or something in an where the causative agent is an infectious disease. So here is a very good depiction of it. So the direction of inquiry, I emphasize, is to the past. So you start with the outcome. So you have the cases, the controls, and you are starting here. So you go back to see among those cases where those who were exposed to the exposure of interest or the risk factor of interest, those who were not looking at the controls, those who were exposed versus those who were not. So the thing to note here is the direction of inquiry is in the past. So you start today, identify cases, controls, and you look in the past. And so the case control studies answer the question, what happened? So what happened in the past? Did the people with the disease have more of the exposure than those who are not? And because you can compare those who have the cases versus those who do not in terms of the exposure, you can actually kind of get a sense of what are the odds of developing the disease that you're measuring. So they are often the best study when you want to really look at association and measure odds ratios. They are the ideal kind of study design for that. So here are some of their strengths. They are great for measuring rare chronic or long latency diseases because you're actually starting with people who already have the disease. So if you have enough people who have the disease, then it's really a great starting point. They're often usually cheap and quick compared to cohort studies. So you just have to pick a bunch of people who already have the cases, select some controls, who are usually not very hard to have, and then you can kind of interview them to see whether they were exposed to the exposure of interest. And they're also good for exploring different multiple types of exposure, right? Like for example, if you take patients who have lung cancer, you can not only look at whether they were exposed to smoking, you can look at whether they were exposed to asbestos or other things that are potential risk factors for the lung cancer. And they are usually useful when randomized control trials are not ethical, like in the case of lung cancer here. And usually one of the key issues that we have with observational studies is this thing called confounding. But one way that you can reduce confounding is by matching the controls and the cases very well. So if you bring people who have similar characteristics, like often similar age, make sure that the gender reflects in both the case and control, and other parameters, you match them very well, you are more likely to have stronger evidence. So they also have some limitations, like cross-sectional studies, you cannot establish temporality or causality. Meanwhile, it can look like the exposure occurred before the outcome. It's not always the case because you have a number of issues. You cannot clearly tell. It's quite subjective. You're taking people who have the disease and trying to ascertain whether they were having some exposure. it's not very objective. It might be better than a cross-sectional study, but it's still not a very great way to tell whether the exposure came before the outcome. So usually they have a very huge limitation with respect to temporality. And so if you can't tell, then you can really determine whether there is some causal effect. And they are also not suitable for multiple outcomes because you usually start with one outcome. So you can study multiple other outcomes. They are susceptible to recall and selection bias. Recall bias because the patient often have to remember whether they were exposed to something. For example, if you take people who have a certain disease, they are more likely to give you to positively say they are exposed that because they already have the condition. They might even already started reading on it before coming for your study. And also the way that you select controls is very important. If you do not select controls very well, you're more likely to have some selection bias and have a mismatch between the control and the cases. They are also it's not even possible for you to do incidence and prevalence and relative risk because you are taking patients and looking back in time. To have incidence, which is number of new cases, you have to kind of look at people prospectively. And so it's very hard to get incidence from there. And also there's this issue of reverse causation. And so reverse causation means that, for example, if you have someone who has a heart disease, and maybe earlier when they started noticing the symptoms of heart disease, they started exercising, right? And if you wanted to do a study where you look at the effect of exercise, effect of exercise on, let me say, heart disease, you could end up with a situation where people who had that heart disease and were exercising early who had the heart disease started exercising early, and you might be tempted to think that maybe exercise causes heart disease. So reverse causation is really a big problem in both cross-sectional studies and in case control studies. So this is an example, a classic example of a case control study, which is a 1950 study, which actually was one of the first studies that raised an alarm that smoking might be a totally big issue. Because before that, there were even adverts where doctors were smoking. They say your doctor's favorite cigarette, and brands were promoting that. And so in this study, Richard Dahl and Bradford Hill, if you know Bradford Hill, he's the one who designed the causality criteria, the Bradford Hill causality criteria. I think it's related to their early investigations with smoking. And so in this study, they compared the two patients who had lung cancer and they took some other people in the hospital who did not have lung cancer. And one thing that they found was that smoking, among those that there was a strong association between smoking and lung cancer, and the odds ratios were like 15. So people who were heavy smokers were 15 times more likely to develop lung cancer. And this was a groundbreaking work because it actually laid the foundation for tobacco control policies that we have up till now. The other study, which is very interesting, is this study that was done in Spain and Colombia, comparing patients, people with cervical cancer cases with population controls. So unlike the first study, which was a hospital-based study, this was a case control study, but was more a community-based control study. And it's kind of the study that brought out the idea that human virus is actually the primary risk factor for cervical cancer. And they observed an odds ratio of more than 50, meaning that patients who were infected with human papillomavirus were 50 times more likely than those who were not to develop cervical cancer. And so this is really the groundbreaking study that lead to what we have now as even HPV vaccination that prevents cervical cancer. So let's move to the next study design, which is cohort studies. So a cohort study follows a group of exposed and unexposed individuals over time to see who develops the outcome. So to give you a sense of how this design works, so imagine you are an investigator, you pick some people who are smoking, you take those who are not smoking, so you have those who are exposed to smoking and those who are not exposed to smoking. You follow them over time to see who develops lung cancer. So you can have cohort studies in two types, prospective cohort studies and retrospective cohort studies. The prospective cohort studies follow patients forward from today. So remember, I had mentioned in an earlier slide, two important concepts, time and direction of inquiry. Where do you stand today? So the key distinction between prospective studies and retrospective studies, it relates to these two aspects. Where do you stand today in terms of your conducting your study, and in which direction are you looking? Note that in both prospective, in all forms of cohort studies, that's both prospective and retrospective, the direction of inquiry is always forward, always forward. What is different is where you start, where you start. So in a prospective study, you are starting, you select your patients, and you start when the patients are selected. So you start really from the outset here. You select your patients, take those who are exposed, those who are not exposed, and you follow them until you get the outcome in both groups. In the retrospective cohort study, you are not starting from scratch. You are taking patients, you're starting somewhere here where you already have the outcome. And you are getting some data maybe from their clinical files or from their clinical records. But note that unlike case control studies, the exposure is clearly happening before the outcome. Although you are starting at the outcome, the exposure occurred before. So this is where I think many people confuse case control studies and retrospective cohort studies. In case control studies, both in case control studies and in retrospective cohort studies, you start with the outcome, but the direction of inquiry is different. In retrospective cohort studies, it's really from exposure to outcome. So, but you are determining the exposure from the patient's records. So these are historical files, and you go back to the records and you get the risk factor or the exposure from there. In case control studies, you start with the outcome, and then you kind of ask the patient if they have some history of remembering the exposure. And so this distinction is very, very critical to understand. The key thing is direction of inquiry. It's very important to make that distinction. So what are the strengths of cohort studies? There is a clear temporal sequence. And so this is very important. The exposure always comes before the outcome. So if you want to do some form of retrospective cohort study where you are not sure whether the exposure happened before the outcome, maybe you don't really have a cohort study. You should think twice. If you cannot ascertain very well that that is the case, then there is a problem in the design. And so this confusion between retrospective, this word retrospective introduces a lot of confusion. There are people who now think you should rather call retrospective cohort studies historical cohort studies, so that it kind of makes sense that you are assessing the exposure historically, so that you don't think about it like just going back in time to collect data, because people think about it in that way. The next strength that it has is that it can measure incidence and relative risk. So you're following the patients over time, you can see new cases emerge. And it's ideal when you have rare exposures, because you are starting with those people who have those exposures already. And they can be great for measuring multiple outcomes. And the Framingham Heart Study is really a great one. They ended up measuring several different outcomes. Actually, 50 years later, they even do stuff on cancers now. And unlike in case control studies, you have less recall and selection bias, because it is kind of prospective. You are not depending on the patient memorizing anything. You're actually objectively measuring it. Unlike in case control studies where it's subjective, you rely on some historical assessment, which is often gotten from the patient. But it has some limitations, right? So they are not ideal for rare outcomes for disease of long latency. So if a disease is rare, you might not end up having too many people who have the case. And so that makes it very weak for you to determine the evidence that you want. They're also often very expensive and time consuming. So you can take maybe 10 years, 20 years, follow patients for 50 years. It involves a lot of staff, a lot of logistics and all of that. So it's really expensive, particularly the prospective ones. And usually need a very large sample size or a considerable sample size and a long follow-up period for you to be able to have a robust cohort study. And there's always this risk of loss to follow up. A patient might move to a new town, a new city, and that introduces huge issues, which can distort the robustness of your study. And they also have non-response bias, which is also kind of related to the fact that you might not have patients showing up regularly for follow-ups. And they are susceptible to sampling bias, observer bias, and ascertainment bias. Sampling bias because maybe the people that you recruit into your cohort are not a very good representation of the study population of the entire. So the sample is not a very good reflection of the entire population. Usually very hard to get a very good representation. So they are quite susceptible to that. Observer bias because the investigators have a tendency to overestimate the outcome in the patients who are showing up more often. And ascertainment bias because it's kind of really, really difficult to know how the condition changes, given that some people might be lost to follow up and some people might move out of town and so on. So this is an example of a cohort study, which is still on smoking. And this was a study that was done still by Richard Doll and Bradford Hill, who did the case control study. They wanted to get more robust evidence to know whether really smoking is really the thing that is behind lung cancer. And so they recruited medical doctors in Britain, and they recruited about more than 40,000 doctors and followed them up for more than 20 years. And what they found was quite interesting. They noticed that doctors who are heavy smokers had a 24 times higher risk of dying from lung cancer, not just developing it, but dying from lung cancer than those who are non-smokers. And they also noticed that by quitting smoking, you reduce the risk of lung cancer by 50% over a 10-year period. And so this study was very important because it provided a definitive evidence linking smoking to lung cancer, which also really led to where we are now. If you pick up a cigarette packet, you'll see some labels there. All of that are a result of this kind of evidence. And this is actually the most robust evidence because you can't really have done a randomized control trials. It would be unethical to assign smoking to one group and not another, like you do in a randomized control trial. So this is actually top-notch evidence. And so this is also a very landmark study, which has been going on for 50 years, the Framingham Heart Study, which I mentioned earlier. So it started off with 5,000 residents in Framingham in the US, in Massachusetts. And this is the study that kind of established clearly that hypertension, high cholesterol, smoking, obesity, and diabetes are major cardiovascular risk factors. And that study had shown that smokers had 2 to 4 times higher risk of myocardial infarction, and that by stopping smoking, you have that risk. And so it really is one of those studies that really improve even the design of cohort studies in general. Like the long follow-ups, imagine 50-year cohort study. And that's really been one of the studies that have inspired so many different kinds of longitudinal studies that we have out here now. So in a nutshell, let's compare these four different study designs that we've looked at. And we are going to look at it in terms of the direction of inquiry, the starting point, what each study is best for, each study's key strength, and their limitation. So starting with case control studies, there is no direction of inquiry. It's really purely descriptive, right? So you start with the individuals with the outcome. You take patients probably who have the condition and you describe it. And usually great when you see something rare, it's new, it's unusual presentation, or you offer a treatment and the reaction of the patient is very different. You want to inform the medical community about that something new or about that that new discovery that you have. So it's really great for identifying or generating hypotheses. And the limit is that usually you cannot infer causality or anything. It's just purely descriptive. The next type, cross-sectional, is usually a snapshot. There's also no direction of inquiry. And each time there is no direction of inquiry, it's very hard for you to know whether exposure came before outcome. So you can ascertain temporality, you can ascertain causality. So you start with the population at one point. So you just take a snapshot. They are best for prevalence. They're also great if you want to just study multiple exposures and outcomes at the same time. They are quick, simple, low cost. Again, no temporality or causality. So when you do your cross-sectional study, always, and you do some form of analytic design, like you can do an association. In the limitation section, always highlight that you cannot establish temporalities. Almost standard in most papers. It's very important to say that, so that people interpret your findings, your associations with caution. Case control studies, the direction of inquiry is to the past, behind. So you start with the outcome. So you get people who have cases, you get some controls so that you can compare. And so they are great for rare diseases or outcomes. They are really efficient when the disease is really rare. It's really great for that. And the key limitation is that they're susceptible to recall bias. So whether the patient was exposed in the past depends on whether the patient can really remember very well. And also the problem that people who have the condition, they are more likely to remember their symptoms than people who did not. So they can over-report the exposure compared to the controls. And also selection bias, because those to select an appropriate control can be very, very difficult. So you can kind of put in some little bit of thinking into how you match the cases and the controls. You cannot assess incidence in this, as incidents are a measure of new cases. For cohort studies, they can be both prospective or historical, which I am now preferring over retrospective. And their starting point is, unlike case control studies, you are starting with the exposure, and they are best for studying effects of exposure over time. That's over time from exposure to outcome. And they are strong. They kind of provide some degree of causality, because they provide strong evidence for temporality. You're always sure that the exposure occurred before the outcome. And so they kind of give something, a close approximation for causality. Although the ideal way to assess causality is through a randomized control trial, preferably that which is double-blinded. But the limitation with cohort studies, again, is that they are expensive, they are time-consuming, and there's the issue of loss to follow-up. So in conclusion, these observational studies are really great for discovering patterns, and especially when experiments are not feasible, as we've seen in the case of lung cancer, where you can do randomize people into smoking. And they're also great because each design provides some kind of different perspective on a certain health parameter or a disease. And they're ideal for generating hypotheses, particularly the case controls, the case series, case report, and cross-sectional studies. And they are also usually a good point for starting research. Like, for example, before you do a randomized control trial, you want to also already have some evidence from observational studies. So these are some of the materials that I read through to prepare the presentation. So thank you very much.